All right, guys, thank you so much for coming into simulation today. Your patient today is Wallace Peterson. You might remember you met him a couple weeks ago during your very first simulation. When you met him the first time, he was a standardized patient. You may have had Wendy Peterson because we had some female patients that day too. So today it's all male, so it's going to be Wallace Peterson. So he was a standardized patient. He was in with pneumonia, and he had been taken off of the IV antibiotics, put on oral antibiotics, and he was being discharged home. So you went in and you did an assessment. If you remember, you found his pulse ox was just a little bit low. We weren't really sure if that was going to compromise him being discharged that day. So you called the doctor about that and educated your patient a little bit because they had some concerns about going home on oxygen. So just a little recap of when you met him last time. So ultimately, Mr. Peterson did go home, but unfortunately he's sick again. So he's back in with pneumonia again, but this time he's a little bit sicker, okay? So just a little review of how today is gonna go. You completed your golden tickets, so we're gonna go over those so we make sure that everyone's kind of on the same page there. And then I'm gonna go ahead and give you a report on Mr. Peterson, answer any questions you have. The scenario itself should only take about 10 or 15 minutes. We'll say about 15 minutes. We will have 2 of you go in at a time. One person will be the primary nurse and one person will be the vital sign tech. And we do that so you have an opportunity to practice delegation. Remember, what are the 3 things as an unlicensed personnel that you can't do? Do you remember?
Educate, assess, teach.
Yeah, exactly. Remember the acronym EAT, okay? And we do that because a lot of times you'll find questions on NCLEX talking about delegation to our unlicensed personnel. So we want you to have that practice here, okay? Whenever you're done with the scenario, we'll do your debriefing for meaningful learning worksheet that you had in front of you, and then we'll do a little group debrief, okay? Do you guys have any questions for me about how today's gonna go? Okay. Let me start by reviewing our learning objectives here. So we have them written on the board, okay? The first one is to demonstrate a head-to-toe assessment, and we said within 10 minutes as evidenced by observation. We're giving you 10 minutes as sort of a goal because you learned in assessment class to do this big, long assessment. We want you to kind of work on narrowing that down to more of a focused assessment, okay? So we want you to have a goal of about 10 minutes, okay? The next one is to identify normal versus abnormal findings as evidenced by your debriefing for meaningful learning worksheet. There's a question on there about that, and also just the discussion that we have. We're going to demonstrate SBAR communication with the provider as evidenced by observation. Whenever you're in the room after you assess your patient, you are going to call SBAR to the doctor. And then we're going to discuss ABGs or arterial blood gas results, and you probably had a thought about that because of the worksheet that you completed, okay? So let's go ahead and go over the worksheet, and we're just going to go from the top to the bottom, shout out the answers, and if you have any questions or there are any discrepancies, we'll kind of dive into that, okay? So what does ABG stand for? I just gave it to you, but somebody tell me.
It stands for arterial blood gas.
Okay, awesome. And what does that mean for our patient?
It lets us know the acid-base balance and how much oxygen is in their system and how their body's compensating.
Perfect, exactly. Does anyone have any questions about that? Okay, so we're going to dive into it a little bit more deeply. So on your worksheet, you were given the ABG for Mr. Peterson. So after reviewing it, what would you say he is in? Metabolic acidosis, metabolic alkalosis, respiratory acidosis, or respiratory alkalosis? What did you decide?
I'd say respiratory acidosis.
Yes. And can anyone tell me why? How did you land on that?
What was pH is 7.32, so that's low.
Yes.
And then also looking at his CO2 levels are pretty high at 52.
Yeah.
And using the Rome method, that kind of helped to eliminate and decipher everything.
Exactly, absolutely. And I wrote that on the board for you too, because that was in your book. The Rome method is a way to remember the ABGs and how to determine whether it's respiratory or metabolic. So the R is respiratory, O means opposite. So your pH and your CO2 are either going to be high and low or low and high, okay? And then metabolic, it means they're equivalent. So if the pH is low, the CO2 is low. So sounds like you guys found that as well. So very good. So let's talk about some possible manifestations of alkalosis and acidosis. So alkalosis, our patient has either metabolic or respiratory alkalosis. What's a neurological manifestation that might happen?
They could be like dizzy.
Mm-hmm.
They may have some muscle cramps if it's metabolic.
Yep, absolutely. How about cardiovascular? What might be happening with their cardiovascular system in alkalosis?
They could hyperventilate and just be breathing really fast.
Okay, yeah, so that's like respiratory, absolutely. And then how about, would that happen during respiratory or metabolic hyperventilation?
Hyperventilation would be to compensate because you're blowing off CO2.
Right, so they're trying really hard to compensate.
Yeah.
So it's
So
probably
it
the
would be
respiratory?
yeah.
Absolutely. How about a cardiovascular manifestation of alkalosis? What might be happening to their heart?
Probably like some sort of dysrhythmia, like electrolytes get involved or
Yeah.
other things as well.
Is there a particular electrolyte that you guys are concerned about that might cause that dysrhythmia?
Potassium.
Yeah,
Yes.
potassium, absolutely. Either very high or very low potassium can cause that, so that's something we want to watch out for. And then how about acidosis? So if the pH is low and it's acidosis, tell me about some neurological symptoms you might see in your patient.
Like confusion or
Mhm.
like dizziness.
Yeah, yeah. And then how about their heart, their cardiovascular system?
They may be, they might have a low blood pressure.
Mm-hmm. Yeah.
You could also have like dysrhythmias with potassium.
Absolutely. Yeah, so their potassium's still involved with the acidosis, so they could have some dysrhythmias. And then how about with their lungs? What's going on with their respiratory system?
So it would be low, so you would get hypoventilation as
Right.
opposed to hyper.
Right. So they're trying really hard to compensate, but they're not really able to when it's that respiratory.
Absolutely.
Absolutely. Do you guys have any questions about just that brief little overview of ABGs? Or any questions about your patient's results that you were given?
Are these his current results right now then?
They are.
Okay.
Okay.
Yeah. These were the last results they got.
Okay.
Okay. Alrighty. The other thing I want to review really quickly before we give you a report is just a reminder about the oxygen devices, because sometimes when we haven't used them for a while, we kind of forget, what goes through what. So with our nasal cannula, how many liters can we put through a nasal cannula? Yeah, 1 to 6, absolutely. So then what's our next, if the nasal cannula is not doing it, what's the next oxygen device we might try on our patient?
Like a sensor-based mask.
Yeah, and how much oxygen can you put through those?
Maybe like to 10.
Yeah.
Yeah, so 6 to 10, so it kind of picks up where nasal cannula left off and goes up to 10. And then what's our big guns?
Non-rebreather.
The non-rebreather. And so that goes from 10 to 15, exactly. Okay. So what I'll do now is I'll go ahead and give you a report on Mr. Peterson. If you have any questions, let me know. If you need me to stop at any point, let me know. And then we will go into the room for room orientation in just a minute. Okay, so Mr. Peterson, Wallace Peterson, he's 69 years old. He is a patient of Dr. Meyer, M-Y-E-R. He was admitted with pneumonia. He has a 6-year history of COPD. He's been hospitalized multiple times for pneumonia and bronchitis. And he quit smoking about 5 years ago. He is divorced and lives with his male partner of 5 years. He has no known allergies and is a full code. His last vital signs were this morning. His temperature was 100.6, blood pressure 144/84, heart rate 102, respirations 28, and his SATs were 88% on 4 liters nasal cannula. And we have had to progressively increase the oxygen we're giving him to keep his SATs above 88%. He was given acetaminophen 650 milligrams for an elevated temperature this morning around 6 a.m. He also had a breathing treatment at that time. Respiratory came up to do that. He has a right AC IV, and he has dextrose 5% and half normal saline running at 75 milliliters an hour. He's on a low sodium regular diet. He is frequently ambulating in the room, but is a high fall risk. He is not in any isolation precautions. Neurologically, he's been intermittently confused. His heart rate is regular, but he's been mildly tachycardic, like low 100s. His lungs sound coarse. He has a productive cough with thick yellow sputum. And his SATs tend to drop with exertion or when the oxygen is removed. He moved his bowels this morning. He's having no issues urinating and his skin is intact. He is up with the assist of 1, but he can be a little bit weak. And like I said, he gets short of breath with exertion. He seems to be pretty frustrated having to be back in the hospital and being so sick. He did report a recent weight loss, and so dietary was consulted yesterday. His ABGs were completed this morning, and just like you found, they reflect a worsening respiratory status. The chest x-ray was last done yesterday and was indicative of pneumonia. He is experiencing some respiratory distress. He appears stable but exhausted. We are continuing IV antibiotics and pulmonary rehab and monitoring his respiratory status closely. He is slightly anxious and confused, so I promised him we'd check in on him frequently since his partner is not here. Anything you need repeated from report or any questions?
How much acetaminophen was he given?
650 milligrams.
All right, thank you.
Sure.
And dextrose is running at what rate?
75. Yeah. Okay, the last thing I want to mention, are there any other questions? I'm sorry. Okay, the last thing I wanted to mention before we go in for room orientation, I meant to mention this earlier, were just some reminders about sim in general. I know this is not your first simulation, but we like to go over it again. First, about your confidentiality. I like to refer to this as kind of like Vegas, lots of fun, lots of learning, but what happens here stays here. You can absolutely tell your peers about your emotional experiences or that you had a great day in sim or you learned so much, but we ask that you not tell them the details of the case because they're coming in later today. We want to give them the same learning opportunity that you had. That also goes for you though. Your confidentiality is protected. What happens here stays here. We won't tell your peers about it. We do record so that we can use it as a learning experience, but those videos don't go anywhere besides in here. Okay, they're just for educational purposes. And then we are working with a mannequin today. So just as a reminder, we don't want you to have pens in the rooms because they can mark up the mannequins, you know, no gum, no beverages, anything like that. And keep in mind, although our mannequin patients can do a lot of cool things, they do have some limitations. So for example, if you wanted to assess hand grasps, we ask that you still do that, tell the patient you're gonna do it, go through the motions, and then I will give you that information verbally. So don't restrict your assessment, you know, based on what you think the mannequin can or cannot do. Okay? Any questions for me before we go into the room? Okay, we'll head on in for room orientation.
Sounds good.
Okay. Alrighty, so before you guys come in to see your patient, we're just going to do a little room orientation. So this is Mr. Peterson. Just like you heard in report, he does have a nasal cannula on. There are oxygen devices at the bedside should you need them. He has his IV fluids running at 75 milliliters per hour, just like you got in report.
Okay.
Just as a reminder of our setup here, we do have the stopcock that allows the IV fluid to run down but then go into a drainage bag under the bed. So you'll see there's a bag under the bed that looks like an IV bag. It's just the collection bag, just don't bother with it. That's all it's there for, okay? He does have his blood pressure cuff over here. We are going to have you guys do a manual blood pressure. We do want you to feel the pulse and count the respirations. It's just good practice to get those manual vital signs rather. He does have a pulse ox over here. So you'll see whenever you put this on the finger, you'll get your pulse ox up here on the monitor. We have your programmable thermometer over here. As a reminder, when you put the probe covers on, just make sure your fingers are on the side here. That way that probe cover can actually stick onto the thermometer, and then you'll put it in the patient's mouth and be able to get your reading, okay? We do have a pen light here should you need it. If there's anything else that you need for your assessment that you don't see in the room, just call a timeout and we can bring that in for you. If at any point you need to clear your head, ask a question, get some clarity, consult with your peer, just call a timeout, okay? And then whenever you're ready, you'll come back in. Whenever you're ready to call the doctor with an update, we do have your SBAR form that we will put over by the phone, just as a reference in case you need a reminder about what SBAR stands for. Okay, and the oxygen on the wall here is air. You can actually dial this up or down to adjust your oxygen should you need to. Are there any questions about your room?
No, I don't think
No,
so.
I don't think
Okay,
so.
remember you can always call a timeout if you need to, if you have any questions or you don't see something, or if something's not functioning the way you think it should, you're having trouble hearing, call a timeout and we'll be there for you. Okay? Okay guys, so you are about to come in and take care of Mr. Peterson. So I always like to go over your learning objectives one last time before you come back in to see him, okay? So just as a reminder, you're gonna be doing that head to toe assessment. You're gonna be identifying some abnormal and normal things with Mr. Peterson. Some things are things you already heard in report and some things you're gonna find out in the room. And then the last thing you're gonna do is call SBAR to the provider to give them an update on your patient, okay? Do you have any questions for me?
So like, is there any cue for like when we should call SBAR, or is it just kind of like?
You know what, that's kind of up to you.
Okay.
You'll kind of figure that out as you come in and you assess your patient. Knowing you're gonna call the doctor, you wanna make sure you have enough information for them. Of course, if something were very critical or emergent, you would call them sooner. But if you have the time to do that full assessment, you get that information and then you'll give them a call, okay? Because they ordered the ABG earlier, but they're not aware of the results.
Okay.
Oh,
Okay.
Sounds good.
That makes sense.
Okay, any other questions for me?
I don't think so. Do you have any questions at all?
No, I think I'm good.
Okay.
Yeah.
So one of you will be the primary nurse and the other person will be the vital sign tech.
Okay.
Okay? All right.
Thank you. Hello, Mr. Peterson. My name's Mitchell. This is Amanda. I'm
Mr.
your
Peterson.
nurse. She's your nursing assistant. We're just coming in to take a peek on you. How are you feeling?
I'm just so tired.
You are. How did you sleep last night? How'd the night go? We're picking up this morning.
I didn't. I've been
Didn't?
breathing hard all night.
Okay.
I'm just so tired.
You seem a little off. I know we've heard things have not been so good with you. How about breathing wise? How are your chest feeling? Like, is it difficult to breathe still?
Oh, yeah, I just feel like I'm not getting enough oxygen.
Okay. Well, how about we sit you up a little bit first? How about that? Especially as you've been sleeping, if you're awake a little bit. And if you're coughing, I'll give you a nice big scoot. Trying to open you up a little bit more. Sometimes when you lay down, that can shut everything off.
Okay.
So have you still been coughing a lot too? Like that hoarse kind of cough that we just heard?
Yeah, there was just so much to get out.
Okay. Well, how about your oxygen right now is on 4? I'm gonna bump you up a little bit just to make things a little bit more easier for you to breathe, okay? So you might feel like a little bit of a higher
off
flow.
My face. I can't breathe with this thing in my nose.
I know, it's a little difficult.
Looks like his mouth is a little blue.
Yeah, I'm thinking thinking we might have to switch to another mask too. Why don't we go ahead and do that? So right now you have a nasal cannula on that's in your nose, that little funky thing that you have right here. But we will get you a face mask that'll go over your entire face. This will hopefully allow you to get more oxygen. So again, it's not the most comfortable thing though, but hopefully it can get you back to a better spot, okay?
Why is this thing on my face? What's happening?
So we're gonna plug this in. This will give you a higher concentration of oxygen than the nasal cannula was. So hopefully this will ease your breathing a little bit more and keep your O2 sats a little bit higher. They were sinking a little bit more lower than we were comfortable with, and the doctor's orders are. So I'm gonna bump you up to 10, and we'll see how that little trial goes.
I'm gonna put this
Why is it so hard for me to breathe?
I'm gonna put this finger probe on your finger, okay?
Can I ask you, have you been using your incentive spirometer at all? Is that giving you any?
No, what is that?
So you see this on your little table. So if you use this instrument, this can actually help to open up and expand your lungs a little bit more. So you just kind of suck in like you're sucking through a straw or like a thick milkshake. So once you suck in through this part, this will hopefully rise, and we're aiming for a higher volume to kind of help open and expand your lungs. If you do that every once in a while, that can kind of help speed up the process of healing and just like popping open your lung alveoli inside as well.
Okay, so
I don't think I can do that right now.
Yeah, we can work on
I
that
don't
later.
like this
That's no
mask. It's really uncomfortable.
Yeah, actually, I'm thinking we're gonna have to bump you to another mask as well.
you just have to go just listen to
Sure.
the respirations.
All right, Mr. Peterson, just hang tight real quick. I'm gonna hook you up to a higher volume concentration of oxygen. This will work the same way as the other mask that you had on before. Just go ahead and take a couple nice deep breaths for me, okay? Perfect. Nice, easy breaths. Good, okay. Get some coughs. Keep taking some nice, easy breaths. Can I start your stethoscope if you're finished with it, or do you think do a couple more?
Just the belt blood
Sure.
pressure. So we have respirations are at 24, heart rate's at 136.
Okay.
So I'll check the blood pressure.
How does that feel with that mask on? I know it's not the most comfortable wise. Breathing wise, are we still working the same? You look like you're a little bit more labored still.
Yeah, and I just feel like I'm still catching my breath.
Right, okay.
What day is it?
Today is Wednesday. So,
Oh,
anything else? And then do you feel that your condition has been worsening, do you feel like, since you got here,
I feel
especially
like
overnight?
I'm so tired all the time. I can't breathe. I feel like I don't know what's going on.
Take a couple nice deep breaths through that mask for me again. All right. Okay. You do sound a little more plugged up still. And based off of, we have your highest mask on to the highest volume possible. And because you're still not feeling so good, I'm just gonna go ahead and give the doctor a call, and let him know your status, and hopefully we can try to get things moving and cruising in the right direction, to get you feeling better so that you don't have to stay like this, okay?
Okay.
Okay.
Oh, I'm so scared.
That's okay, we'll get things worked out. We'll try to be on the ball and try to speed up the process a little bit to try to get this fixed soon, okay?
Okay, why is it so hard for me to breathe?
We're not too sure. I think based off your condition and your diagnosis, you have all that junk still in your lungs, and I think it's just kind of like a time game at this moment. Unfortunately, it's not the funnest game, the most easy game to play, but definitely those deep breaths that you'll be taking through this mask will help, and that'll also help to expand your lungs a little bit more, get that junk flowing. If you feel you need to cough, definitely let that out. We like big coughs. Take a deep breath and then a big old cough, coughing and deep breathing. That can kind of help to move some things around. All right. We'll wheel this back over to your bedside. No need to worry about this for now, but just keep relaxed. Keep taking those deep breaths, and we're gonna go ahead and give your doctor a call and let him know what's going on. Okay?
Okay.
All right.
Hang tight, okay?
All right. So we are going to prepare for our SBAR.
Time out for SBAR.
All right. So that assessment-wise, and we didn't really get too much with that.
Yeah, absolutely.
He's still very cyanotic with a non-rebreather, even though we struck out with the nasal cannula up to full capacity. Even the simple face mask didn't help. Still coughing really loud. Still has that like nasty sputum. And then his spirometer didn't really sound like he was using it, so maybe that played into it a little bit too. Lab levels are still wonky. Like anything else that you can think of that we can alert. How did his vital signs look?
So his vitals were, his heart rate was a little high, at 136. Respirations were at 24. BP was 136 over 86, and his oxygen level is like the most concerning thing, just because the highest we got was an 85. But when we came in, his baseline was 83 on just the nasal cannula.
That's definitely not good at all.
Yeah, so I think that like we should definitely ask the doctor just about another hard-hitting intervention to help him get things moving in his chest, because he sounded really gawky.
Okay. Sounds good to me. So that would definitely be a situation where in a respiratory, let's say like respiratory distress, almost increased work of breathing, still has decreased SATs, and he's cyanotic. The background, obviously we can go through all of his history, assessment, everything that we found, recommendations, stronger treatment.
Stronger treatment, even like a nebulizer treatment.
Yeah, like a more respiratory, harder hitting things. That's a good idea.
Yes, absolutely.
Okay. So I guess we're gonna time back in and call our doctor with SBAR.
Yes.
Time in for SBAR.
All right.
Hi, this is Dr. Meyer.
Hi, Dr. Meyer. This is Mitchell. I'm the nurse caring for Mr. Peterson today. I am with him right now, and he's showing some signs of respiratory distress. When we went in to go check on him, he had an increased work of breathing. He was cyanotic, and O2 sats are now in the 83s, hanging in there in that ballpark. He has the admission with COPD history, pneumonia, which he's in for now, and bronchitis. He's been admitted here for multiple times. Assessment-wise, like I said, he was very cyanotic with low O2 sats. Heart rate a little tacky with 136. Respiratory rate is 24. Blood pressure 136 over 86. Other things that we found, he was still having this hoarse coughs. Coughed a couple times for us when we were with him personally. And he's just not looking the hottest. He's complaining of difficulty breathing. I asked him if he was feeling worse throughout the day, and he said things weren't improving at all. So I was going to ask for your recommendations, and maybe request stronger respiratory treatment. His labs also came back, and he is displaying respiratory acidosis with pH in the 7.32 range and his CO2 levels at 52.
Okay, and how much oxygen is he on now?
He's at the full 15 on a non-rebreather right now. We've tried and progressed through a nasal cannula and simple face mask.
Okay, that sounds good. I want to keep him on the 100% O2, the non-rebreather mask. Let's order a chest x-ray and repeat ABGs, and I think we need to transfer him to the ICU because it sounds like he's decompensating, so I'll meet you there.
Okay, that sounds great. Thank you.
End scenario.
All right, guys, so how did that go?
I think it was pretty good.
I think it went okay, yeah.
Yeah?
Kind of touched all of our bases.
Okay, very nice. Tell me more about that.
Well, we were able to assess, or he was able to assess what was going on and move from the nasal cannula to the simple face mask to the non-rebreather, and then reassess every time he moved up kind of the ladder. And then we were able to come to a conclusion that the SATs were still low and that more intervention was needed. So,
Great.
yeah.
Great. And how about you guys who were observing? How did that go for you?
I think they did a really excellent job, especially with their teamwork. I noticed, and I'm sure you did too, the way you guys worked together was really excellent. There was really great discussion, especially for the S-bar, which was nice because what you said, she agreed with, and she also had something to elaborate on, and I think that was really great, really advocating for the patient, which is really what matters the most.
That's great.
And I feel like you explained to your patient like what you were doing, and you weren't just like, okay, I'm gonna throw a face mask on them. Like you told him what you were doing before you did it, which I thought was really nice.
Yeah, absolutely.
Good teamwork, good collaboration and communication. Great. Well, what this scenario was about assessing a patient who was admitted with pneumonia, who is decompensating, and he's now at a point where he's in respiratory acidosis, and he is in acute respiratory distress, which is what ended up being your situation when you called the doctor, and then calling that to the doctor. So that's what this scenario in general is about. So I'd like to start by talking about oxygenation, because you both brought up the fact that you went from nasal cannula to simple face mask to non-rebreather, and explained that to the patient as he went. So I noticed, Mitchell, that you had changed the oxygen device before you had a SAT. And at first that concerned me, but then I heard you when you were talking about your S-bar, bringing up the patient was cyanotic. And so I thought that was great because it seemed like you were aware of your surroundings and picking up on some other cues from the patient besides just a pulse ox. So tell me about that.
I think that I noticed that myself too. I was like, oh no, I didn't even look at their pulse ox. Like, what are you doing? And I checked it like later in the game than I should have, and I picked up on that towards the end. But definitely, I think like how you were saying, like the cyanosis part just kind of like kicked me in the face a little bit harder than like. I think I just like forgot in the moment to check the SATs and like kind of correlate that with the assessment.
Right.
But yeah, I think that's kind of what went through my head at that moment.
Great. And how about you guys who were observing?
Yeah, I think especially when things weren't getting better, even with the progression, it was very easy to panic and get overwhelmed in that situation, but you both really held your composure and had like a very therapeutic tone of voice, and I know it's a scary situation, especially for him not being able to breathe, and I think that really helped to kind of calm him down a little bit. I think it would have been better to ask him why he was scared instead of saying like, oh, don't be scared, like kind of dig a little deeper, but I think you guys being there and like touching him really, really helped make sure that he knew that you guys were there for him.
I also liked how you guys like raised the head of the bed first, so he wasn't like totally flat or like semi up, so that might have like been able to bring up his stats a little bit. And then you also taught him about the incentive spirometer and like coughing and deep breathing, which I thought was really well done.
Yeah, there were a lot of moments of great therapeutic communication and education that you kind of took advantage of those times while you were in the room. Great. Speaking of communication, I heard you give the great explanation of the incentive spirometer, just like you guys brought up. I was a little concerned about the timing, only because he had the face mask on and he was kind of short of breath. So tell me a little bit about the motivation there.
I think, again, like just like being like flustered in the moment, I definitely should have jumped straight like to the higher guns. Like I think based off of a situation, like if someone's cyanotic, like just like don't even mess around with like fidget with the other stuff, or like even teaching at the moment, like it's probably not all with it at the moment, or just like doesn't even like I wouldn't care if I was in that situation, like very uncomfortable. But so I definitely should have saved that maybe towards like the end, or maybe for another time, or just like mention it. But definitely I think that delayed and in another situation could have been worse, but for his, luckily, it was okay.
Yeah. So tell me a little bit about the assessment too, because we couldn't hear what you were hearing in his chest and how that might have influenced your decision to want to educate a little bit more.
I definitely heard a lot of like coarse like crackles and like really towards like the bottom of his lobes.
Okay.
And based off of like our findings on the X-ray, how they said like it came up with pneumonia, and like hearing that kind of tied in to, so especially with like raising the height of the bed, like immediately I thought like open up his lungs, try to get the gunk moving. He coughed for us in the room, which was like another red flag that beneficial, but like it's more of a symptom in that scenario. But I think all those kind of came at once.
Okay.
Definitely.
Good. So Amanda, I want to talk about the vital signs and that assessment, since you were a vital sign tech. And so I noticed that you went for the pulse ox first, I think. And so I thought that was great because it seemed like you were kind of prioritizing ABCs while you were over there. So walk me through your findings.
Yeah, so he just kept saying that he couldn't breathe and he felt tired. So I just kind of wanted to make sure that first is the respiration is the first thing that I was thinking.
Okay.
I guess the breathing.
Okay.
I can see that he could breathe, which is A, and then B is the breathing.
Yeah.
So I just kind of want to see if he had kind of a lower heart rate. Because earlier on we saw that he was tachycardic.
Okay.
So I just kind of wanted to assess that first.
Okay.
And then move into the blood pressure, circulation, and all of that.
Okay, so you were concerned for a low heart rate?
Yeah.
Okay.
Just to make sure that his heart rate wasn't slowing down or anything, because he said he was feeling weak.
Okay, so you were concerned about the circulation. That's
Yeah.
kind of where you were going with
Yeah.
that low heart
Yeah,
rate. And
yes,
then what
ma'am.
did you find?
And I found that the heart rate was still high.
Okay.
It was at 136, which is very similar to what it was before. And that's when I went on to the respiration.
Okay. Okay. Let's talk again a little bit about communication in regards to the SBAR. So I'm going to ask you guys who were observing. When I was listening to SBAR, I heard, at first I thought I heard situation assessment background, but then I kind of changed my thinking that part of that, that was all one big situation at the beginning. So tell me a little bit, so I was concerned that there might be some confusion, I guess. Tell me about what you heard.
So I definitely felt like that at first, and then when they like broke it down, then you kind of like got the background of it. But at first, I thought we were kind of doing like situation and then the assessment, like you mentioned. But I think after they like went through it a little bit more, then you could feel that you could see those different parts coming together.
Okay.
Yeah, I agree with her. I love that you started out with, hi, like this is my name, this is what I'm doing. I'm here with this patient. This is what's wrong. You did a great attention grabbing. Yes, attention grabbing statement. Because sometimes doctors like are going to be in 6 different places at once. So it's really great that you did that. Maybe shorten it up just a little bit. Give like the very important things, especially because he was decompensating. But I think you guys did a really great job. I really, like I said, love that you did the attention grabbing thing and you really ended up getting to the point and doing it in the correct order. So that was really great. Good job, guys.
Great. Well, before we wrap anything up here, is there anything else about today's scenario that you guys want to discuss?
Not really. I guess from your experience, how would you do anything different than what we did?
That's a great question. So in my experience, the only thing that concerned me, and you kind of touched on it a little bit with the reading of the SBAR, is the time it took to kind of get through the whole assessment and then call the SBAR. Now here in simulation, that's what this is for, is to get that good practice and go through those steps, right? But in the clinical setting, in a real life setting, just like Mitchell, you brought up the sign of cyanosis kind of kicking you into gear, that will happen for you as well when you're in the clinical setting. And so things might just happen a little bit faster, and that will come with experience. So as far as what happened today, it was exactly what I would expect from your level.
Awesome. Thank you.
Very good. Okay, so the last thing we always like to do in simulation is go around the room and talk about something that you're going to take back from today and use in the future. So let's start over here. What is something that you learned today, experienced, felt, saw, that you're going to take back and use in the clinical setting?
I really love how hands-on you guys were with Mr. Peterson, because he was obviously very scared. It's a very scary time, and I think a lot of times we get so honed in on what we're doing. We're not really taking time to pay attention to the patient, even touch his hand. You were doing chest PT, and even though that was something to help him medically, I'm sure even that touch really helped him to make they can know that you guys were there, and just talking to him, that was really great. So definitely, even though I'm sure you guys were scared and panicked, it's important.
Right.
I hope I can take that with me, like to make sure to focus on the patient and like make sure to let them know like I'm present, I'm there for them.
That's wonderful.
Mine would probably be your teaching on the incentive spirometer. I thought it was really good that you like kind of compared it to drinking from a straw, because you can just throw all these terms at somebody and like directions, and then 5 minutes after you leave, they're gonna be like, "Wait, what did you say?"
Mm.
So I thought it was nice that you kind of was like, "Oh, it's just like drinking from a straw." So I feel like that would stick with him more than saying like 12 other different things. So.
I think I'm going to take away just the connection. Like you said, it takes some time to become efficient and a little bit quicker at putting things together. But now that I've had this experience, I can at least take that into the clinical setting. You know, if I see cyanosis and SATs are low and we've moved up to the non-rebreather, call SBAR and really just do those attention grabbing things to make sure that we can get our intervention as fast as possible.
Wonderful. And Mitchell.
I think the biggest thing I learned, and especially like from being in it, is like prioritizing better. So like although like you see like 50 different things going on assessment wise and like even things in your head, prioritizing that, like even like prioritizing the like up to the non-rebreather, like you can just like shoot straight for that. With someone in this condition, like you don't want to mess around like too long because you never know how long it could take for them to get out of it.
Right.
So that kind of stuck out with me, and even like prioritizing in SBAR, so like shoot a quick alerting statement and then kind of hit the details later. I think that's probably like the biggest thing I'll take away from this.
Great, great. And that SBAR will come again with practice. So actually one of the things that you guys are going to do as a post-simulation activity is do an SBAR on your simulation learning system. It's listed under interdisciplinary communication. You're just going to complete an SBAR based on today. And that's just for good practice. So you'll have another opportunity to kind of formulate those thoughts. The other thing that we ask you guys to do is the DASH tool survey. And that's to give us feedback on your experience today. We love your feedback. We use it to make this experience better for you each time. So please give us that feedback. And if you have any questions, you can always reach out to us. Okay, great effort today, guys.
Thank you.
Thank you.